Welcome to EconTalk, part of the Library of Economics and Liberty. I'm your host, Russ Roberts of Stanford University's Hoover Institution. Our website is econtalk.org, where you can subscribe, comment on this podcast, and find links and other information related to today's conversation. You'll also find our archives, where you can listen to every episode we've ever done going back to 2006. Our email address is mail@econtalk.org. We'd love to hear from you. Before introducing today's guest, I have sad news to report. D.G. Myers, who I interviewed last summer, has passed away. His interview was part of the reason I scheduled today's guest, Becky Liddicoat Yamarik, a palliative care physician who had some interesting observations in the aftermath of the Myers interview that she shared with me via email. Myers passed away after the interview with Becky was recorded, so you won't hear it mentioned in today's episode. I will link to D.G. Myers' blog that includes an announcement of his death with charities you can choose to donate to in his memory. Now for today's episode. Today is September 22nd, 2014, and before introducing today's guest, I want to mention we've been creating some additional resources for your education and what we hope is your enjoyment online. Amy Willis of Liberty Fund has been posting at econtalk.org what we call extras, ways for you to check your knowledge and find connections between episodes. And I've been adding afterthoughts on episodes now and then at EconTalk and sometimes at EconLog, our sister site, where we have folks blogging. To keep up with these learning opportunities, follow me on Twitter, which is at EconTalker, EconTalker, which is my Twitter name. And please visit econtalk.org and EconLog if you're interested. And now for today's guest, Becky Liddicoat Yamarik. She is a hospice palliative care physician. Becky, welcome to EconTalk.
Thanks very much. My husband and I are huge fans of the podcast, and I'm very happy to be here.
I am too. Now, this episode grew out of the previous episode we did with D.J. Myers, who talked about living with cancer and how to cope with it, and the fact that he's dying of cancer, and that he's very realistic about that experience. And we're going to talk about that episode eventually, but our main topic is grown out of that, which is the economics of the end of life, the personal and political choices that face patients and doctors. And to me, these are essentially economic questions, not because they involve money, although they sometimes do, or incentives, which they sometimes do, but because they involve choices, how to get the most out of life, which I view as the essential economic question. So I want to begin, Becky, by talking about your job generally, which is a job I'd never heard of until recently, and I suspect it's fairly new, which is a palliative care physician. What is palliative care?
Well, palliative care is a subspecialty that grew out of the need for improved communication and symptom management of patients at the end of life. So people who are palliative care specialists typically have done a year of training after their residency training. Mine was in internal medicine, and then I did a year of training in palliative care, and the focus is on the treatment of symptoms of serious or terminal illnesses. So we focus a lot on learning about how to treat pain, nausea, shortness of breath, depression, lots of symptoms of patients who have things like cancer, emphysema, heart failure, Lou Gehrig's disease. And then the other thing we focus on is helping patients decide on their goals of care, on what treatments make sense, on what their prognosis is, and trying to help patients and families live as well as they can for as long as they can.
But it's presumed, of course, we're all terminal, we're all going to die, but these are people whose death is somewhat imminent, or a disease is taking a course that is irreversible. Is that the case?
It usually is. So, one of the things that happens in palliative care when it's practiced in the hospital is we tend to see patients very late in the course of their disease when they're close to death, and we feel we're better off if we see patients earlier. But we can see patients who are not terminally ill, and so a lot of times in my clinic work, I've treated patients that have very chronic, serious back pain, other chronic pain issues, other symptoms. But it typically is patients who are closer to death. In my residency training in palliative care, every patient who was admitted to the hospital, the admitting doctor had to answer the following question: would you be surprised if this patient died in a year? And if the answer was no, I would not be surprised, then they got an automatic palliative care consult. So that's somewhat unusual. That was in a pretty progressive training program. So we were seeing patients fairly upstream. But unfortunately, most of the time, we tend to see patients very late in the course.
Talk about hospice, because in my mind, hospice is a little cottage with 4 or 5 beds where people are getting ready to die and they're being comforted as they're about to go. That's probably from watching the wrong kind of movie, or maybe the right kind. What is hospice care, and what is a hospice in what forms do they take in the modern world?
Okay, so hospice is a kind of care. It is not a place. The definition from Medicare is in order to be eligible for hospice care, a patient needs to have a prognosis of 6 months or less. Now, that doesn't mean that a patient has to die within 6 months. I mean, there are patients that live longer than that.
They don't enforce it.
Oh, they do and they don't. I mean, they audit you and they see that patients clearly don't meet the criteria, and there is criteria for each disease, then you will have to give Medicare money back.
Yeah, that's not what I meant, but that's okay. I interrupted you. I apologize. I was making a very bad joke, a little bit of dark humor.
I see. They don't. Yes, they don't come in and say, "Okay, your 6 months is up.
Time to go." Yeah.
Yeah, time to go. No, they do not enforce it. So hospice is in order to accept hospice, you have to accept that you have a terminal illness. You need to accept that the focus is on the treatment of symptoms and not on the cure of the disease. And hospice can happen in a home. It can happen in a nursing home. There are some, independent sort of hospice units, but those have somewhat fallen by the wayside, I think mostly because of cost and reimbursement issues. So most hospice, if a patient can't be at home, they tend to be in a nursing home setting. And in hospice, the minimum you get is you get a nursing visit once a week if nothing's really going on and you're fairly symptom-wise fairly stable. But if a lot is going on, a nurse can visit more often. You can have a home health aide that can come typically a couple days a week, but can be more often to help you with bathing. Social worker and chaplain is required. Also, volunteer is required. Through the benefit, you can accept a volunteer. And in our hospice that I work for, we have volunteers that will come for 3-4 hours once a week to help keep you company or take you shopping or do shopping for the caregiver. It's not a 24-hour care service, and a lot of patients and families don't always understand that. The family or a hired caregiver needs to be the person there. And for us, my hospice, the vast majority of patients are cared for at home. There are some patients, maybe 20-30%, that are in nursing homes. And if you have a situation where a patient gets really out of control pain or shortness of breath, there are mechanisms to increase the level of care for us to send a nurse out for 24 hours for a short period of time to try to get that symptom under control, and that's something called crisis care.
How long has this specialty existed? Do you know?
Well, I finished residency in 2003, and I did a little stint doing research, which didn't go that well, and I heard about palliative care in 2005, and I think in my fellowship, which was at the West LA VA, it was the second year that they had fellows. So it's about 10 years old, I think, about.
And what happened? What happened before?
That's a good question. I mean, I've often wondered, why is it that palliative care came about now? Is it something that was really needed? I think a lot of people have this romantic view of the past that somehow before doctors were really great communicators and we've sort of lost that ability, and so we need palliative care to kind of bring that back. I think that before there weren't as many choices. I think one of the problems is in modern medicine, there's a lot of very complicated choices to be made because we have choices, and choices are a good thing, right? I do want to give an example, since you asked me about that, of something a way that I think about how things used to be is, and something that still exists now, is the way that patients are treated with Lou Gehrig's disease, or ALS. And that is a fairly uncommon disease where you become very weak and it's progressive, and you lose the ability to walk, you lose the ability to talk, eventually you lose the ability to swallow and to breathe. And these patients, of all the patients I've treated as a group, I mean, there's individual variation, but as a group, they tend to be the most prepared for the decisions at the end of life. And I've often wondered why that is. I mean, why is it that they're better prepared? And to me, I think the answer is that there's a certainty to this disease. There's like one drug that can sort of slow it down for a while, but that eventually everyone will have to make the decision: do you want a feeding tube? And when you can't breathe anymore, do you want a tracheostomy or a hole in your neck and be hooked up to a ventilator and breathe that way so that you can live longer? And when I've gotten involved with patients with ALS, which is typically when they're hospitalized for pneumonia, sometimes earlier on when they're having issues with pain and other symptoms, they've all talked about the treatments. And I think it's because there's not a whole lot that the doctors have to offer, and there's no room for magical thinking that the treatment's going to work for them, because it's inevitable. They all will die, and they all will die in mostly the same way. So I think it's kind of, ALS is sort of like a window into the way things used to be, and people used to talk more because they didn't have a whole lot else to offer. There weren't treatments that really could cure you.
So you're saying that in the old days, whatever that means, but in the old days, people felt an inevitability about the process once they got to a certain point. And now, because of the innovations in healthcare of all kinds, there's more to choose. Is that some summary correct? Yeah,
I think so. My father graduated from medical school. We both went to Northwestern, and he graduated in 1953. And he tells this story about when he was a senior medical student, staying up all night with a patient dying of liver failure, and how, he talked with him for many hours. He was homeless, and about 24 hours before he died, he pulled out a sort of crumpled piece of paper out of his pocket, and it was a license to practice medicine in the state of Illinois. And he was dying of liver failure because he was a homeless alcoholic. And my dad talks about, what that was like, and talking to him. And I think about, I graduated medical school in 2000, and in 2000, you didn't sit up all night talking to a dying patient. You were, if you were homeless and had no family, you were busy moving them into the intensive care unit and putting them on life support, probably, and running down all their tests and CAT scans.
So you have every medical specialty has some unique aspect to it. One of the things that always fascinates me about the modern world is how specialized it is. And one of the things I often think of as an example of that is medical care. That 100 years ago you were a doctor, period. And now you're not just a doctor. You're not just a cardiologist. You're a pediatric cardiologist, or the specialization is so unbelievable. So your specialty is this interesting mix of talking, listening, helping people decide, providing options, administering options, probably consulting, I assume, with family and the patient in some situations, and the doctors, the primary care doctors. It must be it's a somewhat complex job. But my first thought, hearing about it, is it's a depressing job, because pretty much you don't save anybody. They're all going to die. So is it a depressing job?
No, it's actually, it's not depressing at all. A lot of people ask me that. And, I'll say when I give talks to med students and residents, I haven't helped anyone really live a lot longer in 10 years, but it doesn't mean that my job is sad and depressing. I have a lot, because of my training, I have a lot of skills in communication. And I think that one of the really depressing things for a lot of physicians when they're trying to talk to patients about the end of life is it doesn't go well.
Yeah.
An oncologist will say something like, well, your cancer is really getting worse. You can't breathe now, and your lungs are full of fluid, and, you can't even get up to go to the bathroom. And so I think we really need to start focusing on keeping you comfortable. And some patients and families will become very angry, and they'll say, well, what do you mean? Like, isn't there more that you can do? And then the oncologist will say, well, no, there's nothing more I can do. And we can talk about why that's, not a very good approach. But when, I have a lot of training in, communication and psychology and how to kind of help patients and families accept limited prognosis, understand what their choices are in a way that doesn't focus on abandonment and doesn't focus on
despair.
I'm sorry, what?
Despair.
Yeah, despair. I'll talk a lot about there's a lot that we can hope for. We can hope that, you can make it till your son's graduation next month. We can try to help your breathing get better. We can help your pain get better. But we have to prepare in case things change in the future. And, I also work as a hospitalist. I mean, I am an internal medicine doctor, but I, up until recently took care of regular hospitalized patients. And a lot of times you're doing things that are uncomfortable. You're putting in big central lines in people's necks. You're sending them for MRIs where they have to sit in a tube for an hour. You're, putting needles in their back to take spinal fluid out. And it's painful. And with my job, I just get to help people feel better. So, and you get to learn about, people. You get to learn about their life. I mean, I was a history major in college, so I find people very interesting. That's why I like your podcast a lot. I learn a lot about different, people's history, their past, what, their family life, how they haven't talked to their daughter in 20 years, but, we're going to help them get back in touch with her before she dies. I mean, can be very, very uplifting.
That must be extraordinary. And there must be some days that are very moving and uplifting like that, but there must be some tougher ones too.
Yeah, I mean, I think when it's really hard when people don't, when they're in denial, and denial can be a protective thing. I'll tell the residents that you don't want to just sort of break down someone's denial, but you want to kind of help them move along. And sometimes you'll just see patients who are going to die and they're not accepting it, and so you see them suffer a lot. Get a lot of life support treatment and things that are not going to help them, and make choices that you don't agree with. But it's a free country. We don't live in a totalitarian state, so you have to accept that even with the best communication, some patients will make choices that you don't think are good.
Well, let me ask you about the psychological side, though. One of the things I really liked about D.G. Myers, because it reflects some of the understanding I have of the way some people at least feel about disease, is he talked about how much he hates the phrase battling cancer, and this idea that there's something heroic about it. But there is a belief, and I think it has some basis in science, maybe it doesn't. There is a belief that optimism is healthy. Optimism, that not giving up, denial, what you're talking about right now, it's good because it helps the patient, marshal some enzymes and I don't know what else, but that it's healthy. Do you think that's true or not true?
That's a good question. I mean, I think that for some patients, denial can be protective. And if they're not ready to accept a limited lifespan, that denial can protect them.
But is it productive? Does it help them fight the disease?
I think that's really hard to measure.
Yeah, I do too.
So I don't know. I sort of have some of the concerns you voiced before.
So this raises a question I've often wondered about, which is how much control people have over when they die. My favorite example of this, I probably mentioned this before on EconTalk, but John Adams and Thomas Jefferson both died on the same day, July 4th, 1826, the 50th anniversary of the Declaration of Independence. And of course, it could just be a coincidence, but I felt that psychologically they had a desire to make it to that day. And they may have, quote, given up in some dimension before that and died sooner if it weren't for that arbitrary 50-year anniversary. Do you see that phenomenon, people hanging on till some event and then seemingly giving up and going?
Yes. I think, as I said, you see it when there's some event that or somebody wants to live for. In Southern California, where I work, we have a lot of immigrant patients. So oftentimes we are trying to get, people across the border from Mexico, and patients will wait to try to see their relative. We will help patients get to South America, and a lot of patients will make it till they die there. So seeing someone or making peace with a family member can be really important for people. And so people will, suffer through a lot. I read somewhere a family member of a dying patient said that, death is not painful. It's the resistance to death that is painful. And so, patients will resist it if there's something important for them or if they can't accept their death. I do, though, think, one of the things that I feel a lot is that, death, people will joke and they'll say, well, in America, you all think that death is optional. And Europeans will say that about, our escalating costs at the end of life and how many people go to the intensive care unit. But I do think there's some aspect of death. The time of death is a choice now, because when you have a terminal illness, like say you have advanced cancer, even if you come into an emergency room and you are actively dying and everybody looks at you and says, this patient's dying, typically what will happen is the family member who's with them or the patient will be asked, well, if your heart stops beating or you stop breathing, what do you want us to do? And we can talk about why that's a terrible thing to ask, but why it happens. But they get asked that, and then typically the patient will say, well, I want you to do everything. And so even though everyone recognizes they're dying, the patient will get put on a ventilator to help them breathe and given medications to keep their blood pressure up, and they'll be whisked off to the ICU. And then the decision will have to be made later to withdraw the life support and allow what we call natural death. So that is a really common scenario. So in order to actually die, like people have to make this almost conscious choice, because medical care is this runaway train that will just keep you going and flog you over and over until, either you decide enough or, you just die despite best effort.
Even in the face of that. So you talked about what was rewarding about your job. Are there things that you find harder than others? For me, it seems unimaginably difficult. And the communication part, you mentioned how doctors have trouble communicating bad news. Most people do, and certainly doctors are not selected for the ability to deliver bad news in a way that's helpful or comforting, and that you've been trained in trying to do that. It must be still incredibly hard. Are there some days that are really tough that you come home and you think, this is too hard?
Yeah, I think, up until recently, I worked as a hospitalist and doing palliative care in the hospital at one of the University of California hospitals. And that was very challenging. One of the things, too, is kind of trying to interact with the other doctors, in a way that is productive for the patients and the families. And a lot of times, say if you have An example is what case I worked on where a patient had really advanced disease in his aorta, and so his aorta, this is the big blood vessel in the belly, burst, and he was a man in his mid 80s, and that's about a 50 or 60% mortality rate if you have that happen to you, but you can do an emergency surgery, and so he had the surgery, and he had it repaired by a very good vascular surgeon at our hospital. And I actually saw the patient before he went to the operating room, and I was actually working as a regular doctor. I was hospitalist and doing medical consulting, which is to try to help optimize the patient for the surgery. And I because I'm a palliative care specialist also, I asked the patient, I said, things don't go well, and you don't recover well. What is a quality of life that you need to have in order to want to live longer? And he said, I don't want to live in a nursing home permanently. I don't want to live hooked up with machines. And so he had the surgery, and he didn't do well. I mean, he'd had long-term rheumatoid arthritis. He'd been on steroids for a long time. He had kidney failure. All of that got worse. He was on dialysis. He was unable to come off the ventilator, and he, you cannot stay on the ventilator for more than typically about a couple of weeks before a decision has to be made. Either you are removed from the ventilator and allowed to die, or you're what we call trached, where you have a hole put in your neck and you're hooked up to the ventilator that way, and you have a tube for feeding. And I met with the surgeon and the family many times, and it was really hard because I knew what he had said, and I also knew that, was it impossible that he wouldn't recover from this? Well, no, it wasn't impossible. But people that get trached and pegged and sent to a facility, the typical survival, mortality in a year is somewhere between 50 and 60%. And someone who's 82 and who had just had a ruptured abdominal aortic aneurysm was a lot lower than that. And so it was really hard because the surgeon is a really great guy, really caring doctor. But he said to me, I said, you really want to trach this guy? I mean, you really think that that's the right thing to do? And he said, well, I'm just not ready to give up yet. I really think there's a chance that this guy can pull through. And, when I'm working with patients and families, I try to say, well, you have to, it's their decision. It's not your decision. And it's hard. So like these, and I don't want to fault him. I think he's very caring. But the patient did end up getting trached and pegged and transferred to what we call an LTAC, a long-term acute care hospital. And we can talk about the growth of those and what that means for medical care later. But it was, those kind of things, when you feel like patients get treatments that they wouldn't have wanted, and, that's hard.
But surely you must have the opposite situation, too, where a patient says, I don't want X, Y, or Z. You give them X, somebody forces them to take X, Y, or Z, and then they're glad. Do you ever have that? I mean, it strikes me that knowing what we want at the end of our lives, when we're people would say, well, you should make that decision when you're in good health. But of course, it's not obvious that you're fully informed. It's not something we get to experience lots of times and get practice with. So it seems like an inherently difficult problem.
Well, yeah, I agree. And it's very difficult, and it's hard to know. I mean, you may say right now, as you're a healthy man, fairly young, you may say, I wouldn't want to live if I ever had to go live in a nursing home. That just would not be acceptable to me. But later on in life, maybe that choice comes up, and maybe at that point you're like, well, this is better than being dead, so This isn't so bad. So to say things like, I would never want to live, if X, Y, Z, that we call that advanced care planning, and I think it's helpful, but I don't think it's a perfect solution. I'll give the example of my own father. He's 84. And he's an ophthalmologist, very, bright, active guy. And 2.5 years ago, he crashed into a tree, broke 5 vertebrae in his neck, almost died. And he had told me before that he was kind of extreme. He said, I never want to live if I'm in any way mentally impaired. He'd watched his brother die of Alzheimer's, and he's like, I don't want to be in any way mentally impaired. If I'm at all mentally impaired, don't do anything to keep me alive. And I'm like, okay, that's a little extreme, but okay. Well, now he has some mild brain injury. I mean, he gets confused. He probably couldn't live alone. I mean, he does get along very well, and he can still read. I mean, he can't practice medicine, but he's very happy. He's a happy guy. In some ways, he's happier now than before.
Yeah.
But it's kind of an example of the limitations of advanced care planning. I mean, I think the main thing that you can do is to choose someone to speak for you. That's what we really stress is the most important thing. So the person that you pick should be the person who knows you the best, and that's why legally, if there's no one directed, it's always your spouse followed by your adult children. But that's probably, and then to have kind of conversations with that person about, mostly to give them permission to say, well, if it looks hopeless to you, or if, I get to the point where I can't, communicate in a meaningful way, or I can't toilet myself, I can't get up out of bed, then to me, that's not really quality of life.
So you and I talked before we recorded this about an interesting phenomenon that this brings up, which is it seems that the best person who could speak for you would be your spouse or your children. But of course, they're complicated sometimes, and their relationship with the patient's complicated. And sometimes they're eager to try treatments for themselves on behalf of the patient rather than what the patient wants, because they have their own motives, their own desires, they want the patient to live longer so that they can reconcile with them or whatever it is. So that must be incredibly difficult.
Yeah, those are really challenging situations. And a lot of times families who are more cohesive, for whom the relationship is better, oftentimes have an easier time letting go. And sometimes it can be families who there's a lot of anger and unresolved issues. A lot of times we'll have families where there's multiple children, and they have differing opinions. Some haven't seen the patient in 20 years, and they're often the ones that want to keep the patient alive because they feel guilty, or there's other issues. I mean, sometimes you see sort of interesting economic things come up where, say, someone is getting money from Medicaid for in-home support services, and you think to yourself, well, is this a conflict of interest? They want to keep them alive, because quote unquote they get the check.
Yeah, an awful thought, but probably sometimes relevant.
Yeah, it can be, and it can be very tricky how you bring that up. I mean, I think more frequently I see people make decisions that are economically very bad for them because they really want to continue keep a patient alive, like they forego work, or the money they're getting for in-home support is much less than they could make otherwise. So I do see that happen a lot more rarely, but I see docs, people a lot of times say, well, you have to put all these other things aside and just think about what the patient would decide if they could speak for themselves, and that's your job. So what we call, that's a very kind of American individualist way of ethical, surrogate decision making. You're the spokesperson for the patient, and what would the patient say? And that, that can be useful, but then in California, we have a lot of cultures for whom, the individual and their, self-determination is not as important. So sometimes, I'll have, say, an Asian family who feels like, no, the most important decision maker is the family, and it doesn't really matter what the patient wants because it's the family that comes first, not the patient. So you do actually have to learn a lot about kind of other cultures and how they make decisions, and, it can be very humbling and very interesting.
Yeah, the other thought I had, which we're going to talk about in a minute, is that, of course, it's very hard to be that Smithian impartial spectator because you, of course, as the doctor or as the family member, have various incentives that are impinging on you related to that decision. And it's easy to convince yourself that you're doing what's right for the patient when it's actually better for you. So that's always, I think, the incredible challenge of these situations. Having said that, I'd rather have it be a family member than probably a stranger appointed by the hospital or the government to make those decisions. So there's no easy way out of these. These are inherently tough. I want to turn to something that came up in the D.G. Myers episode that you wrote me about, which is you really liked the fact that he wanted honesty. When he had a certain amount of time left to live, say it was 3 years or 5 years or 2 years, whatever it was. And of course, there's no certainty about these things, but he appreciated when his doctors told him the truth, and he really resented it when they sugarcoated it or pretended things were going to turn out otherwise. Why is that so important, and why did that resonate with you?
I think, it really resonated with me because I feel like in my work and in, my friends and colleagues who work in, say, cancer or pulmonary and cardiology or geriatrics, where you're dealing with, very sick patients who are terminal, it can be rare. I mean, when someone comes in and they said, I want to know my prognosis, I want you to tell me how long I have, you sort of breathe a sigh of relief because you're hoping that they will ask you. And many times,
why? Why is that important to you and to them?
Because they're giving you permission to talk about that the end of their life is coming, and then it opens up the door to make choices about treatments that either can help enhance the quality of life that you find acceptable or, just to kind of talk about preparing. I mean, we talk in palliative care a lot about this idea that we should try to help patients have, what we call a good death. And one time I heard someone give a lecture, and they said that Yogi Berra once said that the only good death is someone else's. So, I mean, nobody wants to die, but, a good death is one in which you've prepared, you have your affairs in order. I mean, I can't tell you how many times a patient will come into the hospital, and I was working as a hospitalist, and we'd admit the patient, they'd had cancer for a year, metastatic, terminal cancer for a year, and they come in with a pneumonia, and that's going to be the end of their life, and the spouse is sitting there crying, saying, I don't even know anything about the bank accounts or where any of the money is. And you just think to yourself, are you kidding? Like, they're so unprepared. And then they wind up in the ICU, and then for, no reason, on life support, and then the family has to make a decision to stop it. I mean, it can be very, very hard. And a lot of times, I'll see patients. I mean, so here's a patient from last week. Patient came on to hospice, metastatic pancreatic cancer, 61 years old, diagnosed in April. Had a rapid decline. None of the chemotherapies had worked. And she stopped chemotherapy a month ago, but she didn't come on to hospice until 3 days before she died, so she went a month kind of with a lot of pain, a lot of symptoms. Her oncologist was trying to manage it. And I talked to the oncologist, and he said, I talked to them about hospice, and I thought it might be a good idea, but they said that they weren't ready. And that's kind of much more typical of the type of the interaction that I'm seeing compared to patients like D.G. Myers. And it could also be that I get involved in the cases that are very difficult. And, we do get a lot of patients that get on very early, who forego treatment. But it just seems like and I hear from oncologists, it's very hard for them to refer us patients to hospice earlier because the patients don't want to hear it. They're not ready. So let's talk about the incentives for that to happen, to not be ready, because that's one of the things you and I talked about before this recording, and I think it's very, very interesting. So what are the incentives facing an oncologist to encourage realism and versus
false hope. And of course, there's a gray area here because it's not cancer and disease generally is not predictable. There's some statistical regularities. When you say there's a 50 to 60% chance, some people say, "Oh my gosh, 60% chance that I'm going to make it. That's phenomenal." Others say I have a 40% chance of dying. It's over. So, and of course, we don't really know what the chances are for any one person. We're talking about statistical averages for a population to the extent we know them. So, you've suggested to me that oncologists have a natural incentive to encourage treatment. In the book I've written about Adam Smith that's coming out soon, I talk about how if you have a hammer, everything looks like a nail. If you're a surgeon, everything seems that it's going to be helped by surgery. So it's hard for us to think about doctors that way, but it can be true. So talk about what you've observed in that area.
Well, oncologists have a very, very hard job. There's a huge expectation that patients will do well. And so, and they're more so in that specialty than any other, patients will doctor shop. So a friend of mine who's a fellow in oncology at Stanford told me, you have to have a thick skin to be an oncologist because your patient is always, you have to assume they're always going to go get a second opinion from someone else. So if a patient comes in, who has advanced metastatic cancer, and I have another friend who's an oncologist on the East Coast, and her mother spent 3 years dying of ovarian cancer when she was a fellow. And so she really feels like, she's seen it up close. She feels like it's important for patients to understand that they have a limited time. But she said she started doing that when she started practicing and being, honest and open and realistic. And then she's like, my patients all left. They all went down to the academic center, in downtown, in the city where she was at. And, they were all much more hopeful and they had lots of studies and, they just wouldn't be negative. So I think, patients when they get diagnosed with cancer are terrified. They're often at that point not ready to hear bad news. And, the oncologist, unless you have a lot of training, and I asked my friend, I said, well, why do you think it's so hard to, to refer patients to hospice or to stop chemo? And she's like, I was never taught. She's like, I was never taught how to have those conversations in fellowship. I was taught how to give chemo, but I was never taught about psychology. Palliative care wasn't, part of our training. And I think that's true. When I was working at the University of California Hospital, I had to sort of beg the oncology service to let me give lectures and let the fellows spend time with us. I think that's changing now, which I think is good. I think people are getting more training. But I think historically, they're not trained in it. So a lot of times an oncologist will make kind of what we think of as a mistake. So say, a patient has an advanced disease, chemo is not going to be helpful, and they really think the patient should stop. They'll make the error of they'll link the suffering that the patient's going through with an insistence that they should accept death. So they'll say something like, well, your cancer's getting worse and you can't breathe and your lungs are, filling up, you're too weak, so we should just make you comfortable. And then the reason the patient reacts badly to that is that they feel abandoned. And there's different ways to bring that up in a more productive way, but the oncologists don't have that experience of how to do that properly. And so then what happens is they have that happen. They have the patient get angry, maybe leave them, and then they think like, well, no, what's the point? I mean, I have 22 patients to see today in my office, and if I try to open this can of worms, everybody just gets mad, and then I start running behind, and there's no incentive for me to do that. Why should I do that?
But it's a little worse than that, right? Because the oncologists make money from giving chemo. Is that correct?
So that's an interesting question. They did. So up until I think about 2006, 2007, the oncologists would buy the chemotherapy drugs and then they would get reimbursed by Medicare, but they would buy it for much less than the cost of the drug. So they were making money on the chemotherapy. And, one of the things that Medicare does keep trying to do is plug these holes where there's perverse incentives. So they did change that. So I think it's still, I don't know how much that still happens. I think it probably does to some extent, probably not as much. But one of the big things in general in medical care is that we are a volume-based system. We get reimbursed on volume. So if you see 2 patients in half an hour and, you're going to make more money than if you spend an extensive time with one patient over half an hour. So the kind of conversation where you're trying to convince someone to go on to hospice and stop chemo is a much longer, more involved conversation than saying, like what happened with my pancreatic cancer patient, when she was getting weak and sick, the oncologist said, well, why don't we try to stop chemo for a while and see if you feel better? And then we can see what happens. So that's kind of typically, and so then you push the conversation, the reality, off to another time. So I think time, chemo may be a part of it, but you see it even in docs who are, salaried, at either Kaiser's or academic centers who don't make money on chemo. So I do think it's part of it. I don't think you can, I think there's many different pieces. So I think that is an aspect of it, but also it's a time. I mean, doctors complain mostly to me that they don't have the time or the skills to have these conversations. And they're not incentivized to do so. So another thing that's interesting is, and it's come up a lot in palliative care, this idea, should there be a detriment? If you give chemo to a patient within 2 weeks of death, should that be something that counts against you in some way? Right now it doesn't. And to oncologists' credit, it only happens somewhere between 5 and 8% of the time. But it happens in surgery. So in surgery, your 30-day mortality is tracked carefully and published, I believe. So surgeons are, will talk openly and say, well, I'm not going to do surgery on you because you have a very high chance of dying, and I think it's too risky.
But this is nuts. Do you realize how, this is your world, Becky, so it's normal to you, but for me on the outside, right, it's like, think about this, and I'm very sympathetic to this idea that, that some treatments aren't very, very helpful and they're just done just because people feel they have to do everything, and that sometimes that hurts the quality of life. But the idea that I want surgery, but the doctor doesn't want to do it because it might be bad for his stats. It's like the guy, to pick a really unfortunate, weird but very accurate analogy. At the end of the half in basketball, there's a guy has the ball 60 feet from the basket. It used to be with 1 second left, you'd throw up a shot. It's a really low probability, but you might make it, and it's a 3-pointer. But now people don't even take them because they don't want it in their denominator of their shots attempted because they're probably not going to make it. So that's what you're telling me. And of course it's crazy already because the patient might want the surgery partly because they're not, or the family might because they're not paying for it. It's being paid for by the government or by insurance or whatever. But this is crazy. Do you think so? Do you see that?
I do find it interesting that you're becoming out, that the thing that you're becoming outraged about is the withholding of medical care. And that's just sort of an interesting aside.
What, in 2014, because we, quote, spend too much? I'm open-minded to the possibility we spend too much. I think we do spend too much by the definition of if we had to pay for our own medical care and rely on charity, there'd be less medical care. A lot of it was not, I don't think, money well spent because we're spending other people's money. But I certainly don't think it's inherently bad to do. I like medical care. I'm a big fan.
Well, I will say that, it could be a bad analogy because there's many things that don't count. So like the patient coming in with a trauma who's almost dead, and the only way to save him is to do, emergency surgery, or the patient who has a ruptured AAA, abdominal aneurysm like our patient whose mortality is 50-60%. I mean, many surgeons take patients who have very, very high mortalities. And so it's probably not a good thing to spend a lot of time on because I don't know as much about it, so it might not have been a good idea.
No, I take the point. I'm just, and I certainly, my poor grandfather died after open heart surgery when he was in his 80s, and I saw him when I went to see him when he was in the hospital. He was just so frail and so sad looking. I'm thinking, who thought it was a good idea to open this poor little man's chest? Now, of course, if he'd survived, I'd have thought the opposite. So maybe it's just the probabilities, and it's hard to assess them. But the idea, though, that someone would not want to work on me because he thinks I'm a long shot is a little bit scary. That's all. That's all I meant.
But why is it more scary than people going, to the intensive care unit, being putting on life support machines when they're 98% dead, or our intensive care units being referred to as, one pulmonologist I worked with said she feels like she's working in a warehouse for the dying. That doesn't seem to upset people as much.
I don't know. I'm not sure. That might upset me plenty if I knew more about it. So it's one of my questions for you. So talk about a topic you had sent me in advance, which is how deaths changed in the United States and the massive growth of ICUs. I don't even know about that, so tell me about it.
So intensive care units are, where it started in the 1960s. Before that, they didn't really exist, and life support, kind of as we know it, didn't really exist. So if you were, say, a very old patient with advanced Alzheimer's dementia, typically those patients will all eventually die of either pneumonia or a urinary tract infection. That's the mode of death. So, an 85-year-old comes in with pneumonia. She's breathing very fast. She would die unless the antibiotics started working and her lungs got better. People who trained in the 60s and 70s and even into the 80s, you would see a lot of patients die. But starting in the late 80s, say 90s, and then when I was in med school, death becomes a choice. Someone can come in very elderly and very sick, and unless they have what we call a do not resuscitate order, they will be put on life support because, say you're an ER doctor, you have a really busy ER. You can't spend a lot of time on this sick patient that comes in from the nursing home who's breathing 40 times a minute, less than 20 is normal, figuring out, do they have either they do have a do not resuscitate or they don't. And if they don't, even though they're 95, I have a high level trauma coming in 6 minutes and you're going to get intubated and sent to the ICU. So the ICU growth has been just phenomenal. And we have more ICU beds per 100,000 than any country except Germany. I think has a little bit more, but most European countries have much, much less. So like the hospital that I did work at, the University of California Hospital, had 250 beds and about over 60 ICU beds. In med school, I did a rotation in England in one of their ICUs. And in England and in most European countries, the decision to put someone in ICU still resides mainly with the physician. So the physicians, if someone comes in and they're, elderly, have a chronic illness over 80, those patients don't get put on life support. They don't go to the ICU like they do here. But here they go unless they have a do not resuscitate order.
But it seems to me the key question is, what percentage of the people it's a chilling, it's disturbing. The question is, how many of them get off it and get back to life of those put into the ICU? That would seem to be the relevant question. The fact that we have lots of beds, that could be a good thing, but it doesn't depend on how many make it. How many do we know?
Well, in general, the immediate mortality rate is 10 to 20%, which doesn't seem like much, but that's really high. And it's hard because one of the things that you probably would find interesting is that one of the things that's very regulated in the American healthcare system is hospital length of stay and ICU length of stay, because Medicare will pay a hospital not according to how long the patient stays, but according to the diagnosis that they come in for, or the main diagnosis of the stay. So there's a big push, and that's one place where palliative care can be helpful to a hospital's bottom line, is there's a push to keep patients on a short length of stay. So a patient comes into all right, so here's an example. Patient with advanced emphysema and Alzheimer's dementia on dialysis, 85, comes in to the hospital with pneumonia, gets put on life support, and cannot wean off the ventilator, meaning we just can't get them off the ventilator. The lungs are too weak. And the family, after multiple conversations, still wants the patient to be on life support. Well, the hospital does not want that patient to remain in the ICU. So what they want is to either withdrawal of life support and allow natural death, or what they call trach, peg, and transfer, which means you put a tracheostomy in the neck, hook them up to the ventilator that way. And by the way, they can't talk when that's in. Put a feeding tube in the stomach and transfer them to something called an LTAC, or a long-term acute care facility, which the definition of that is a hospital with an average length of stay of more than 25 days. And that's where a lot of these patients that can't be weaned go. The mortality in those LTACs for a trach and pegged patient is somewhere between 50 and 60%. So over half of patients will die in a year. And what's interesting is that 10 years ago, there were about 100, a little over 100 of these facilities in the United States. There's now over 400. And
it must be a non-trivial portion of our healthcare costs too, right?
It's massive.
So,
right?
So on the surface, that's, I don't know what to make of that, to be honest, except that, it always reminds me of F.A. Hayek. The curious task of economics is to demonstrate to men how little they really know about what they can imagine they can design. And once you have this totally messed up, weird compensation, pricing, diagnostic, medical care system that's not anything remotely related to a market exchange, some perverse and strange things are going to happen that you have to always wonder about. But on the surface, without knowing any of that, just looking at the fact that we spend an enormous amount of money with only a 40 to 50% chance of survival could be a wonderful, inspiring story or a very depressing story. I don't know what to make of it without more information. So I guess the question would be, you say it's 50 to 60% mortality in the LTAC. So the 40 to 50 who get out of there, are they back in 3 days and they die anyway? Or do they get to go home and play tennis, or what happens to them?
Right. So that's a big question. And, there are some portion of them that will go back to living independently, meaning, maybe a quarter of them will be able to live at home. But a huge percentage of them, maybe half of those who survive will spend the rest of their lives in a nursing home. And so I think, there's definitely a place for this. There are patients who just really need a prolonged wean and can't get off the vent in 2 weeks, and it's realistic. But I think what we're seeing over and over again are these very old patients with multiple comorbidities. People on dialysis, people with dementia. Dementia itself is, very, there's a lot of people with very advanced dementia from nursing homes who are getting things like dialysis and multiple hospitalizations. And so to see a patient, another thing that I haven't talked a lot about, but one other sort of thing that I'm doing is helping a Medicare HMO. So this is a Medicare insurance company, and they get paid per member per month rate, and to cover all the costs. And they're interested in trying to improve care at the end of life, but they're also interested in improving their cost issues. And so they've started a program where nurse case managers develop a phone relationship with patients who are terminally ill and help them understand what their options are and help them talk about hospice and other options. And it can be seen by detractors as, you're just kind of shipping everyone off to hospice because you just want to save money. But they are kind of filling a void. And what I've been doing is help train them and train the nurses in how to have these conversations. And then every week we get together and the nurses tell me different cases that they've had that have been challenging. And so, I think to kind of, shine an example, this was just last Wednesday's patient. So a 76-year-old male who has Alzheimer's dementia, and he has renal failure. He's not on dialysis yet, but he's getting close, emphysema. And he has had 8 hospitalizations since January and 5 nursing home stays after the 5 of the 8 hospitalizations. And he's just continually getting weak. And his last hospitalization resulted in him being put on a ventilator in an ICU for 3 days. So the nurse, the family's kind of dysfunctional. The sons don't talk to the patient's wife. The wife's estranged from the patient. And in each of these hospitalizations, no one ever has tried to get the family all together and talk about the fact that this man is slowly dying. And do we want to keep just re-hospitalizing him, sending him to nursing homes, all that kind of thing, or do we want to really try to kind of let him know what the prognosis is? And no one had done that, right? The hospitalist hadn't done it. The primary care hadn't done it. So the nurse was telling me about all the different conversations she had, and she finally was able to get through to the hospitalist to say, will you please just let hospice come in and evaluate the patient and talk to the family? And she did, and the patient got discharged on hospice, and now he's on hospice. He's still alive, and he's doing well. But 8 hospitalizations in 9 months, kind of crazy.
No, the whole, just, it strikes me as, again, as a non-specialist, an outsider. And by the way, I have to make my joke, which is people say, well, you're a doctor. And I say, yeah, but not the kind that helps people, because I do have a PhD, but it's in economics, alas. As an outsider, it's just such a strange system we have created / helped create, with a situation where, from the outside, it seems reasonable for a lot of people to say it's time for you to give up. But on the other hand, and these are patients, I assume, who don't want to give up. On the other hand, it's just strange that anybody would make that decision. There's no obvious answer as to who should make that decision. A panel of experts, a panel of insurance experts, a panel of doctors, a panel of clergy, a panel of ethicists. It's just family members. They're all flawed. So the current system is just what's disturbing about the current system, of course, is that it is, whether it's designed that way or not, its effect is to spend enormous sums of money with perhaps very little return. But on the other hand, some of that return maybe is precious. I don't know.
Yeah, it's very hard. Like when people will say, I can't believe they're going to give that new chemotherapy, which only prolongs life from 6 months in kidney cancer to 10 months. Like, that's just silly. And I'm like, yeah, but if it was your last 10 months of your life, that's like a 40% improvement.
Yeah, 2/3.
I mean, so I'm not here. So I'm not saying that these are not the things that, we should stop doing these things. I mean, yes, they're very costly, and but I'm just talking about kind of the low-hanging fruit, which is, patients who are clearly dying, who are suffering a lot. But I do think that one of the big reasons that it happens, is that doctors have not been trained and are not reimbursed adequately to have conversations about the end of life. They're not educated about prognosis. I mean, if you ask, a lot of doctors, well, what's the number one thing that tells you how long a patient with cancer is going to live? Well, the number one thing is how functional they are. Like, do they get out of the house? Can they get dressed by themselves? And how that's changed over time. Most people don't know that. So doctors don't have as much education as they could about predicting or about prognosticating, and there's not a stress on psychology of conversations. And even something as simple as, doctors should never say there's nothing more we can do.
Right. It's just, you're right. It's like, let me just flip the switch off here. Let's turn out the lights and go home. Yeah. It's a real, it's the wrong strategy.
Or with DNR. I mean, we haven't talked about DNR, which is, nobody's educated in a systematic way about how to have a do not resuscitate discussion, and people will say, well, if your heart stops or beating or you stop breathing, what do you want us to do? And that's like, and that they assume is shared decision making.
Yeah.
Well, you haven't given a lot of key information there, like, is it going to work and what's going to happen after,
Yeah,
So
for sure. It's incredibly, incredibly challenging, moral, ethical, personal, physical. A lot of what we're talking about, I assume, is technological. The fact that, thank God we're better at keeping people alive, but it does come with a set of complications that, as you say, we're not so able to deal with. We're out of time. Let's just close on something a little bit different, if you're able to talk about it. We talked about your job, and we've heard a lot of the ups and downs of it. Why did you choose this? If you'd like to share that, why'd you go into this specialty?
Well, I'm not a sort of the typical person who probably would have gone to medical school if my father hadn't been a doctor. I don't think I would have been interested because I was a history major in college. I found science really hard and kind of dull, and I decided to go to medical school, and then enjoyed it when I finally got to talk to patients. And I chose internal medicine because you actually got to talk to patients more, and I like that. And then, as I said, when I finished residency, during residency, when I was working in the oncology unit, I was very struck by how much I saw patients really suffering. And I got the nickname of, "Oh, you're the hospice honey," by the social worker. She's like, "You always want to put everyone on hospice." So, I think I was kind of attuned to seeing, the suffering and being disturbed by it. I did end up, after residency, doing a research fellowship and realized that I was spectacularly bad at research, and I was never going to be one of those people that was going to bring in big grants. And then I met this economist who later became my husband and introduced me to EconTalk. I was following him out to California where he got a job, and that was where I first learned about this specialty called palliative care, which was all about like talking to people. And it seemed like something that was right up my alley. So that's kind of how I got into it. And, I think it's very, I've kind of been, saying doctors don't know how to talk to patients and there's all these problems, but, there's a lot happening now with that. That is changing. And I do think there's a lot of, room to be hopeful that, that Medicare is talking about, paying doctors for having conversations. And, I've actually, different groups have been asking me to, hospitalist groups have been asking me to give, talks and educating them. They don't want to pay me for it yet, but maybe that will actually happen at some point. But I do think there's more awareness of the problem. And, when I first started, I would recurrently be called, "Oh, you're Dr. Death," or "You're Dr. Kevorkian." And I found that like deeply offensive. And,
really?
Because I don't support physician-assisted suicide. So, but, things are getting better. I think, it's just going to take a while, and there's probably always going to be problems, but there's room to be hopeful. Things are changing.
My guest today has been Becky Liddicoat Yamarik. Becky, thanks for being part of EconTalk.
Thanks so much.
This is EconTalk, part of the Library of Economics and Liberty. For more EconTalk, go to econtalk.org, where you can also comment on today's podcast and find links and readings related to today's conversation. The sound engineer for EconTalk is Rich Goyette. I'm your host, Russ Roberts. Thanks for listening. Talk to you on Monday.